Okay, let's unpack this. Welcome to a very focused deep dive. Today, we're really zeroing in on a super important topic for your MSRA revision. We're pulling directly from your pediatric notes, measles, or rubeola, as it's also known.
Mm.
Our mission here, basically, is to take the structure you've already got in your notes and turn it into something really high yield, a sort of memorable mental map.
Right. Make it stick.
Exactly. We're going to walk through the essential points, highlight what, really stands out, and connect the dots just to help solidify this for your revision.
Sounds good.
We'll cover the core stuff just like you've laid it out,
Mm.
defining measles, the cause, how it spreads.
Risk factors, what's happening pathologically.
Yep, differentials, what else it might look like, the epidemiology, the big picture.
Clinical features, of course, how it actually presents.
How we investigate, management, prognosis, those tricky complications, and prevention, definitely prevention.
Okay, let's do it.
Right, let's jump straight in. Starting at the very beginning, what exactly is measles?
So basically, it's a viral infection, highly contagious. It mainly hits the respiratory system, but everyone knows it for those classic symptoms, right? The fever, cough, runny nose, red eyes, and of course that telltale rash.
And the specific virus causing it.
It's an RNA paramyxovirus, specifically a single-stranded RNA morbillivirus. Knowing that family, it helps place it.
Okay. And how it spreads this seems crucial.
Oh, absolutely. It's incredibly infectious. Spreads through the air, respiratory droplets when someone coughs or sneezes. And here's a really key point, especially for revision. The virus can actually survive on surfaces for up to 2 hours.
2 hours, right. That explains a lot about how it gets around in places like clinics or schools.
Exactly. That surface viability is a big factor.
So once someone's exposed, how long until they get sick? And maybe more importantly, when are they contagious?
Good question. The incubation period, so from exposure to first symptoms, is usually around 10 to 14 days. Often there's a prodrome, that early phase lasting maybe 2 to 4 days within that. But the really, really high yield bit for public health is the infectious period. People can spread it starting 4 days before the rash even shows up.
Wow, 4 days before.
Yeah, and they stay infectious for about 4 days after the rash starts. So they're spreading it when they might just feel like they have a cold. That's a huge challenge.
That pre-rash spread. Yeah, I see why high vaccination rates are so critical then.
Precisely. And the flip side is once you've had measles, you generally get lifelong immunity.
Okay. That brings us neatly to risk factors. Who's most likely to catch it? Sounds pretty straightforward from the notes.
Yeah, they really are. The main risk factor, being unvaccinated or obviously not having had measles before.
Mm.
And then, as we said, close contact,
Yeah.
especially in crowded places where those droplets and contaminated surfaces are, more of an issue.
Makes sense. So moving on to the pathophysiology, what's the virus actually doing inside the body?
Okay, so it starts by latching onto those respiratory epithelial cells, the lining of your airways, basically.
Mm.
From there, it spreads pretty quickly to the lymph nodes, then hops into the bloodstream, and then it's kind of systemic.
And the effects, what does it lead to?
Well, it causes a degree of immune suppression, which is important. It makes people more vulnerable to other infections. And alongside that, significant inflammation. Interestingly, that classic rash, it's not just the virus damaging the skin directly.
Oh.
It's largely your own immune system fighting back. It's the result of the immune response targeting infected cells in the skin. The rash is a sign of the battle, if you like.
That's a great way to think about it, the immune system at work. Okay, let's talk differential diagnoses. Someone comes in with fever and a rash. Measles on the list, but what else should be on your radar?
Absolutely vital, this. Especially where measles isn't common anymore.
Yeah.
The list of mimics is surprisingly long.
Mm-hmm.
You've got things like rubella, parvovirus B19, various enteroviruses, scarlet fever, even more serious stuff you really don't want to miss, like meningococcemia or Kawasaki disease. Other possibilities include human herpes virus type 7, maybe dengue, depending on travel, or even things like HIV or secondary syphilis in the right context.
And simple things, too.
Yeah, sometimes even just a drug allergy can present similarly. So seeing that broad list really hammers home why just diagnosing clinically can be unreliable.
It really does. Highlights why you need that broad differential and high index of suspicion sometimes, which leads nicely into epidemiology, the bigger picture.
Right. And the key thing, certainly in the UK, is that measles is a notifiable disease. You have to report suspected cases.
And the overall trend, thanks to vaccines.
Well, the good news is the MMR vaccine has massively reduced cases. Huge impact. But outbreaks can and still do happen, usually in communities where vaccination rates have dipped.
The numbers kind of tell that story, don't they? Like 810 cases in the UK in 2019, down from over 2,000 a few years before, but still definitely present.
Exactly. And those vaccination coverage rates are key too. Often pretty good for the first MMR dose, but there's often a drop-off for the second dose by age 5. That leaves a gap.
Yeah, I saw that gap noted.
And comparing internationally, like the U.S. nearly eliminating endemic measles but still getting imported cases, it just shows how connected everything is globally.
Okay, let's shift to the bit everyone sort of pictures when they think of measles. The clinical presentation. The sequence here sounds really key for revision.
Totally. It starts at that prodromal phase.
Yeah.
Think of it like a nasty cold, but with a fever. Patients are usually irritable, coughing, runny nose. That's the coryza and mild conjunctivitis, so red eyes.
And then comes that almost pathognomonic sign, the one that pops up before the rash.
Yes, coptic spots. Got to know these. They look like little grains of salt on a reddish background, inside the cheeks on the buccal mucosa. Small white or maybe bluish-white centers, seeing those before the main rash is a massive clue for measles. Really high-yield sign.
So, prodrome, coptic spots, then the rash. Tell us about the rash itself. What's its pattern?
Right, the measles rash is quite characteristic. It usually starts behind the ears,
Okay.
then spreads to the face and neck, and then works its way down the body, trunk, and limbs over a few days. It starts as these discrete, flat red spots with maybe little bumps, maculopapular, but then they often merge together, becoming blotchy, confluent.
And how does it resolve?
It fades after about a week, usually in the same order it appeared top to bottom. The little memory tip spreads down, fades down. Sometimes, as it fades, you might get some skin peeling, desquamation. But importantly, this usually spares the palms and soles. That could be a helpful differentiator.
Got it. Spares palms and soles. Any other symptoms commonly tag along with the rash?
Yeah, about 10% or so get diarrhea, plus general malaise, feeling unwell, maybe a sore throat, some swelling around the eyes, and often sensitivity to light, photophobia.
Okay. But you mentioned earlier, even with these classic signs, clinical diagnosis isn't always foolproof, especially where it's rare. So how do we actually confirm it?
That's exactly right. The clinical picture can be strongly suggestive, no doubt, especially with coptic spots and that rash progression. But lab confirmation is considered necessary.
Necessary for definitive diagnosis in public health, right?
Precisely, for tracking and control.
So what are the lab options?
The mainstays are looking for measles-specific IgM antibodies. You can test a salivary swab or a serum sample. These antibodies usually pop up around the time the rash starts. Or you can detect the virus's RNA using PCR. Again, often from a salivary swab or maybe a nasal swab.
And I saw a note about preferred samples for surveillance.
Yeah, Public Health England guidelines often prefer oral fluid of samples. They're easy to collect, non-invasive. And you can test them for IgM, IgG, which helps check immunity and the RNA itself.
Makes sense. What if you can't get oral fluid?
Then serum and a mouth swab are the alternatives. Especially useful maybe in very young kids.
And why is this lab confirmation so critical? What does it allow us to do?
Well, several things. It confirms the case definitively, especially important if there's a potential outbreak. It helps assess the risk of secondary transmission, who else might be at risk. And it allows for timely post-exposure prophylaxis for contacts who need it.
Okay, great. Let's talk management. Once it's confirmed or strongly suspected, what do we do?
Right. Key point here. There is no specific antiviral treatment that targets the measles virus itself.
No magic bullet, then. So treatment is mainly supportive.
Exactly. It's all about supportive care. Making the patient comfortable, that means rest, plenty of fluids to stay hydrated, and managing the fever and any aches with things like paracetamol or ibuprofen.
Is there anything specific that's sometimes given? I saw vitamin A mentioned.
Yes, good point. Vitamin A supplementation is recommended, particularly for severe cases, or in young children in high-risk areas, or if you suspect they might be deficient. Evidence suggests it can help reduce how sick they get and the risk of death.
Okay. And beyond treating the individual, managing measles is also about stopping the spread, right?
Absolutely critical. That involves isolating the infected person so they don't pass it on. And, crucially, vaccinating anyone susceptible around them to build that protective wall of immunity. The MMR vaccine is just fundamental here, part of the routine schedule in the UK and many places.
When might someone need hospital admission?
You definitely consider hospitalization for patients who are at high risk of complications. So think immunosuppressed patients or pregnant women. And, worth repeating, Remember that legal requirement to notify public health as soon as you suspect a case.
Yeah, definitely. That notification then kicks off the whole contact management process, doesn't it? Which sounds like a big deal.
It is, and it's a really high-yield area to understand for controlling measles. So if an unimmunized child has close contact with a confirmed case, the advice is to offer them MMR vaccination within 72 hours of that exposure.
Within 72 hours, can that actually stop them getting it?
It can often prevent the illness entirely, or at least make it much milder. It's effective post-exposure prophylaxis.
Okay. What about contacts who are more vulnerable, where maybe the vaccine isn't the right immediate step?
Right. For vulnerable contacts, think infants under 6 months who are too young for MMR, pregnant women who aren't immune, or immunocompromised people. Vaccination might not work or be advised. In those situations, we often use passive immunization with human normal immunoglobulin, HNIG. It gives immediate but temporary protection.
Okay, immunoglobulin for the vulnerable contact.
Yes, and it's also vital to check the immunity status of any healthcare workers who might have been exposed.
Got it. Okay, let's look at the prognosis. What's the usual outcome?
Well, for most healthy people, measles usually resolves without any lasting problems. But, and it's a big but, the picture can be very different for those vulnerable groups we mentioned.
So who's at higher risk for a worse outcome or complications?
Complications are much more common and can be much more severe in young children, especially infants, and in anyone who's immunocompromised.
And what sort of complications are we talking about here that affect the prognosis?
The big ones that really impact outcome are things like pneumonia, that's a major cause of death, also ear infections, otitis media, and neurological problems like encephalitis, inflammation of the brain.
And looking globally, the prognosis varies hugely, doesn't it?
It really does. It's quite stark. In developed countries with good healthcare access, the case fatality ratio, the CFR, is really low, maybe less than 0.01%. But in developing countries, particularly where there's malnutrition or limited access to care, the CFR can be over 5%.
5%, that's huge.
It is. And globally, it still causes around 100,000 deaths every year, making it a leading cause of vaccine-preventable death worldwide. Still.
And does age affect mortality risk, too?
Yes.
Yeah.
Risk of death is higher in infancy and also in adulthood compared to kids aged about 1 to 9 years old.
Wow. It all just keeps pointing back to prevention being absolutely key.
It really is the cornerstone. The main tools we have are effective vaccines and, in certain settings, vitamin A supplementation.
And the MMR vaccine is central to that.
Absolutely. Getting the MMR vaccine on schedule is the single most effective way to prevent measles. And like we said, giving MMR within 72 hours of exposure can work as post-exposure prophylaxis for healthy contacts who aren't immune. Importantly, the notes mention vaccinating then doesn't seem to worsen an infection if it's already incubating.
Good to know. And for those vulnerable contacts where MMR isn't the immediate answer for PB.
That's where the immunoglobulin comes back in, providing that passive immunity boost. Crucial for infants, pregnant women, and the immunocompromised.
Right. Now, let's maybe dive a bit deeper into the specific complications listed in your notes. This is where measles gets really serious.
Yeah, this is important stuff. Some of the most serious and relatively common complications include pneumonia, again, a very common cause of death from measles, otitis media, the ear infection is very common too, and encephalitis, brain inflammation, while less common, is incredibly serious.
And the neurological complications can be particularly nasty, even long-term.
They can be devastating. You have the acute encephalitis that happens during or just after the illness, but then there are these rarer but awful delayed neurological syndromes. The main one is subacute sclerosing panencephalitis, or SSPE.
SSPE. Tell me more about that.
It's this progressive degenerative brain disease that develops years, often 7 to 10 years after the initial measles infection. And sadly, it's uniformly fatal.
Wow, years later.
Yeah. There's also measles inclusion body encephalitis, MIBE, which is rare and tends to affect immunocompromised patients, often progressing more rapidly.
Are there issues beyond the lungs and brain?
Yes. Gastrointestinal problems are pretty common, especially diarrhea. Less often you might see clinical hepatitis or issues like hypocalcemia.
Any other notable complications?
Measles can worsen or even trigger vitamin A deficiency, which can lead to eye problems, even blindness in severe cases. It also causes temporary immunodeficiency, that lingering lymphopenia, making patients susceptible to other infections for weeks or months after. And in pregnant women, measles is particularly dangerous, leading to severe illness for the mother and potential complications for the pregnancy itself.
And who's most likely to end up with these serious complications?
It comes back to those vulnerable groups again. Anyone immunocompromised, malnourished individuals, those with underlying vitamin A deficiency, and pregnant women.
And there's a crucial link back to vaccination here regarding complications, isn't there?
Absolutely. This is a really powerful point for revision. Vaccination doesn't just prevent measles infection itself. It also dramatically reduces the risk of some of the most severe long-term complications, especially SSPE. Preventing that initial measles infection through timely vaccination is literally life-saving years down the line by preventing SSPE.
That's a hugely important takeaway. Okay, wow, we've really covered the ground there, working systematically through your notes on measles. Let's try and pull the key threads together for your revision.
Yeah, let's summarize.
So, what should really stick? Measles. Highly contagious, airborne, and surface spread.
Distinct clinical pattern,
Mhm.
that prodrome, then the Koplik spots, key clue before the rash, then the characteristic top-down rash, spread and fade.
Right. And while that clinical picture is strong, you need to remember that lab confirmation is essential for definitive diagnosis for public health, especially where measles isn't seen much.
Exactly. And management. It's supportive care, rest, fluids, fever control, plus vitamin A in specific situations.
But the ultimate weapon, individually and for the population, is vaccination. MMR.
Absolutely. Prognosis is generally good in healthy people in well-resourced settings. But don't forget the potential for severe, even fatal complications, especially in vulnerable groups. And those stark global mortality figures really drive home why it's still such a major public health issue, despite being preventable. Understanding who's at risk for complications is key too.
So, building that complete picture transmission, signs, diagnosis, management, complications, prevention, using the structure you've already got in your notes.
Yeah.
That seems like a really solid way to revise this for your exams.
Definitely. Connecting all those pieces is crucial.
Okay, so maybe one final thought to leave you with based on everything we've just discussed. Measles is almost entirely preventable. We have a safe, effective vaccine, yet it still kills around 100,000 people globally each year, mostly children. And we still see outbreaks even in places like the UK that had it well under control. What does that persistence really tell us, about the ongoing challenges in global health? Things like equitable vaccine access worldwide, but also tackling vaccine hesitancy closer to home.
It's a sobering thought, isn't it? Shows that public health is so much more than just the science. It's deeply tied into societal factors, access, trust.
Yeah, something to mull over. And that pretty much wraps up our deep dive into your measles revision notes. Hopefully this conversation has helped, pull out those high-yield points and make the information feel a bit more connected for you.
Yeah, hope it was useful. Keep reviewing that outline in your notes. Focus on those key links we talked about. You've got a solid base there.
Definitely. And for more resources to help you absolutely smash your MSRA revision, do make sure you check out pathomsra.com.
And freemsra.com as well. Lots of good stuff there.
Great. Well, thanks for joining us for this deep dive. See you next time.